that can support the Global Coalition's work, and they will document those, and we will post those on our website in the month of June. That's the second sector. The third sector is the private sector, and we have an engagement plan that we are currently finalizing and will be presented at next month's meeting. Now, another initiative that I'd like to discuss is a new communication feature that we will be posting on the Coalition website, which I previewed last month, which will allow participants to share content. Think of LinkedIn, Facebook, YouTube, where you can post content, videos, documents, narrative. You can react to other people's posts, ask questions, pose comments, and you can translate the text into your language as well. We are going to go live in February with this feature, and it will require account activation from Coalition participants. So in the coming weeks, you will receive an email that will invite you to create an account on our Coalition website and then begin posting content. And so we welcome you to do that and to share your recommendations for the Coalition, to post any news articles, to share experiences, and most importantly is really to share the recommendations that you have from your perspective and in looking at the working groups where you're participating in. We very much are eager to hear what you have to say. And I want to conclude today by covering the initiatives and pledges. In other words, what the calendar looks like over the next few months. When I discuss initiatives, I'm referring to programs, actions, and policies. And we asked the international organizations to provide us with a list of their initiatives that they recommend to undertake through the Coalition. Well, between December and January, we received over 100 initiatives from international organizations. So we've been very busy looking at that menu that has been proposed. We will be posting that menu of initiatives on our Coalition website over the coming weeks. And that is the work of January to February. What does that look like? Let me give you an example of one. We will have as a topic an initiative or a project. We will have a small description, a brief description of that initiative, followed by background that will provide documents or videos, other background documentation. We will discuss the accomplishments of that initiative to date, if it's an existing initiative, the activities, what are the steps of undertaking that initiative. We will include outcomes at a global level and a national level. We will include the names of countries that are currently participating, if any, and a point of contact in case you are interested in participating as well in this initiative. Going further, in the month of February, we will continue posting these initiatives on the Coalition website. They will be updated regularly with more and more and more content. And then between February and March, we will be asking all of you to make pledges that will be to identify those initiatives of interest and to express interest directly with the implementing organizations and the points of contact listed for those specific initiatives. Then in March, we will have further discussions around these initiatives. I know many of you will be attending the Commission on Narcotic Drugs, the CND in Vienna, so we look forward to further discussions there at that time. Finally, between April to July, we will begin our implementation phase, and that implementation will last several years, but the initiation of that will be between April and July. So we're very excited to actually bring this into a concrete action between our countries. Now, I also want to end by discussing a bit of the recommendations for the Coalition as well. Our team has been reviewing the topics from the monthly Coalition meetings, and we have been creating a draft list of recommendations for reaction from all the Coalition members. So in the month of February, we will be sharing a draft list of recommendations with the co-chairs, and we will also post it on the website so you can all start reviewing that and also consulting with your governments on those recommendations. Then on March 6th and 7th, we will have a meeting of the working groups where the sub-working group co-chairs will present to the working group co-chairs the progress that the coalition has made to date, along with the recommendations. And we look forward to your input, your reactions to the discussions on that date. I will mention, however, that we will then in the month of March post those recommendations on the website and continue to welcome further input from all of you participants on those recommendations, particularly using that feature that I mentioned, which will be posted on the website, where you can all provide your comments and input. So I will stop sharing my screen. That's all for my presentation today. I know that was a lot of information, so I will just say that if you missed it or you want to hear it again, I will be back in 55 minutes to start all over again with those comments. And now I'd like to turn it over to our co-chairs for today to get us started with our session, and look forward to the presentations for today. Thank you so much.
Thank you, Brian. Our dear co-chair, Dr. Hetty, is having some technical issues. Tonight is the night for it, so I will introduce our first presentation. It's a recording from Dr. Charles Parry. He's the Director of Mental Health, Alcohol, Substance Use, and the Tobacco Research Unit at the South African Medical Research Council. And the recorded presentation will be on building, sustaining, and growing drug epidemiology networks. Cyril, if you could please start the recording, that'd be great. Thank you.
Thank you. I have 13 slides, but I won't comment on everything in the slides. So the topic of my presentation is, let's just move this out the way, building, sustaining, and growing drug epidemiology networks in Africa, just as an example, a 25-year perspective with particular emphasis on the SWG, which is the South African surveillance system, and SENDU, which is a Southern African surveillance system, which is no longer operating. Move the slide. Okay, I want to talk about the birthing of SWG, and I'll explain what SWG refers to. So it all started with an invitation I had to attend a meeting of the International Epidemiology Network on Drug Use in Vienna in May 1995. And that's a picture of Zili Sloboda on the bottom right, who was one of the leaders of this initial meeting. And I was asked to present on drug abuse in South Africa, and it exposed me to the work of other epi networks, such as the one by the Pompidou Group and the US Community Epidemiology Working Group on drug use. It connected me with key players working in this area, and it exposed me to the methodological aspects of epidemiology networks. And it also led to a 3-week consultation at what was then the UNDCP on the International Drug Abuse Assessment System, which was a predecessor of the Annual Reports Questionnaire. And I also got invited to the US Community Epidemiology Workgroup meetings every June after that. And we had ad hoc meetings of this international network. And this meeting led me to establish the South African Community Epidemiology Network on Drug Use, which is SWG. So what it is, it's been in operation now since 1996. It's a network to collect data on alcohol and drug abuse in South Africa. And its objectives are listed on the left. It's to identify changes in the nature and extent of alcohol and other drug use and emerging problems, particularly to identify changes in negative consequences associated with substance use, to inform policy and planning and advocacy, to support networks of local role players, to stimulate research that's identified as being important to identify, so that we can find out what's going on in the drug and alcohol space. And it's also to facilitate our full participation in international fora and to help us to fill in the Annual Reports Questionnaire. So the current system really has 3 data sources. It's collecting data from all 9 provinces in South Africa, and it collects the data on a 6-monthly basis and collates it 6 monthly. So the core elements currently of the data system are treatment demand data, where we have information, demographic information. We have information collected from people coming to these 100 treatment centers around the country on the primary and secondary drugs of abuse. The mode of use, are they injecting, smoking, ingesting in other ways? Have the people had prior treatment, or is it a first treatment episode? Who's referred them to treatment? Questions around, have they been tested for HIV? Because we have a strong relationship between drug use and alcohol use and HIV. And also we ask questions about different comorbidities. We also link that with what's called a service quality measure. It's not only important to find out why people are going to treatment, but also we collect data on their treatment experience, quality of services given. And there's also, recently, we've added components around community harm reduction services. The exposure of people to various forms of harm reduction, needle exchange programs, other kinds of methadone treatment, and so forth. So the sequence of data collection, there's every 6 months, data is collected from these different sources, the treatment centers, from community harm reduction program initiatives. It's collated, particularly at the treatment center data. It's also collated in terms of the harm reduction services provided. It's the data is captured, there's an analysis phase, and there's a report back every 6 months in different parts of the country. We also allow for presentations additional presentations, maybe there's been a household survey or some other form of data collection that's important. So not just the data on the treatment system, the service quality, and also the harm reduction, but other data sources that happen to be available at the time. Past research, we've collected data from other sources that you can see there on the left. So psychiatric data, police arrest and seizure data, but we're finding that hard to get at the moment, but we're planning to bring that back in. We've got data on mortuaries, arrestee data, trauma unit studies, and sometimes we've had data on wastewater surveillance as well, but these are not every 6 months. So the key features of that support the SWG data system are stable leadership in a stable institution. My unit has been collecting this data. We have funding from the government at the South African Medical Research Council, so it's in a stable environment that's got the resources to manage this. We initially had strong external support from the UN, from WHO, and also particularly, you can see a picture at the bottom. From the bottom left there, you'll see Nick Kozel, who was involved for many years at the National Institute on Drug Abuse in the US and managed the US Community Epidemiology Work Group on Drug Use. Initially, we got funding from the World Health Organization, but now we have local funding from our Department of Health and Social Development. What also sustains it is 6 monthly meetings. We have regular report backs in different formats, reporting short reports, longer reports. We adapt to change. Now we're collecting data online. It's linked to other initiatives such as the other projects. Graduate training is linked to it. The service quality measures project I've mentioned, harm reduction, so forth. And it feeds into our reporting to the annual reports questionnaire every year. Then we led to it, we were asked in 2000 to help write a proposal to the Southern African Development Community, and we rolled out SWG from the 9 provinces in South Africa to 13 other countries. You can see them listed there in terms of the order at which they were rolled out and the date at rolling them out. We provided training supported by the UN and SADC. It was rolled out sequentially. So we started with, I think, the easiest countries, and we ended up with countries that were more complex because of what was going on at the time. The last 2 countries were the Democratic Republic of the Congo and Angola. Main data sources across the countries were treatment demand data, police arrest and seizure data, and psychiatric hospital data. This was largely secondary data, although we introduced forms to collect the treatment data, as I described earlier. We had funding from the European Union through the Southern African Development Community for funding country report preparation and funding to attend 6 monthly meetings. So I think that was key. All the countries came every 6 months together, and those that had been rolled out presented their data, and other countries could then see how the data was collected and being presented. We also married it at some points in time to training for countries in completing the annual reports questionnaire. And we released 6 monthly reports, country reports, and an overall report for those countries that were on board at the time. And we ended up with 14 countries providing data. One of the things we do, and I'm not going to go through this in any detail, is as the data are reported by countries, that's the data from specialist treatment centers, if they have it, the data from the police arrests and seizures, and also from the psychiatric hospitals, is we try to identify implications for policy. We also identify, as the data are presented in PowerPoint presentations, what are the issues that are emerging that we want to watch in the next 6 months, so issues to monitor, and also areas where we think further more intensive research should be carried out. That's not to say we necessarily had the funding to carry out the research, but we at least put it out there that these are important topics needing further research. The successes of the SENDU, the project in the 14 Southern African countries, was we launched the networks following technical support visits of 1 week in each country. We had 6 multi-country report back meetings in different countries, and you can see the dates held there in the second bullets. We prepared various technical support documents on how to collect the data in the psychiatric hospitals, the format for police arrest and seizure data, the treatment data, and so forth. And we translated them into French and Portuguese, and we had various written outputs, including 10 6-monthly reports covering data across the countries that were on board at the time. The project unfortunately formally ended when the EU funding ended, but some of the countries continued to collect data. There was, we had at the end, we had an internal process evaluation, and the report was dated May 2005. So obviously it's outdated, but I think this model could be replicated if there was a need to roll it out again. I don't think the model was not successful. It was the funding that ran out. What worked, I think, was ongoing technical support, very important. Agreement on core indicators and data sources, establishing within country epidemiological networks and country focal points. We collected data at most sites. A couple had challenges. We had regular 6-monthly meetings. It was linked to political structures. So when we had our 6-monthly epidemiology meetings, they were held alongside meetings of political counterparts who were looking at what to do about drug abuse in the country. And we would present the epidemiological data in those forums. There was information dissemination. There was some funding, moderate level of funding. So that's what worked. There were challenges, as you can see there. There were language differences. It was quite costly to have interpreters. Communications challenges in some countries. They had challenges with internet, but I think those difficulties have probably largely been addressed now in the time that's passed. There was a lack of commitment from some of the political principals to contribute funding to the project, which was the intention all along. Instability in some countries. You can read them there. I won't go into all of them now. We're running out of time. There were recommendations given in that report on how to strengthen the project around funding, technical support, how to expand data sources, and particularly to improve the quality of data. So this, like the ARQ, this is something that was rolled out with the intention of improving quality over time. So I think that's a model that can work. You don't go for the best, the gold standard you start small and you improve over time. We had some comments on how to improve the analytic capacity at the regional level. And we have some recommendations to how increase the policy relevance of the data coming out of the system. And one of the challenges is you get changes of people working at a country level. So we certainly recommended that there should be 2 focal points in the countries, and because to keep it going, if someone moves to another department or dies, unfortunately, we had one of our colleagues die of malaria. So almost finished. What was the influence of the Secendo system and the regional, the Sendo system? What was the influence? Certainly, we presented at AU expert meetings in Addis Ababa in 2010. We also used the system to help train people in Nigeria to set up a similar system. We also provided training to the West African Epidemiology Network. We've provided technical support coming out of this to Senegal, to the Pan-African Drug Epidemiology Network. And we also, as I said, submit country reports annually to as South Africa, to the African Union. Reflections on building such networks. I think certainly you need regional and national support. There is a need for some funding. We didn't find the network that expensive, but bringing people together 6 monthly or at least annually, I think would be key if you're developing a regional network. Ideally, these projects go from being just a project to a program that is embedded within and supported by government departments, rather than as a research project, which was how the Sendo system first started out. You need champions to drive this at country and regional levels. There are boilerplates, which I think can be useful in helping countries get on board if there's any appetite to rolling this out again. One should have a small win strategy. As I said, be flexible, steadily improve it, and improve data collection, improve data validity, improve analysis and reporting over time. And that can happen when you have 6 monthly meetings and bring people together. And I've come from the 2.1 Working Group West just now, and I think one needs to increase compatibility with national and international reporting systems to reduce duplication. So that's it. Thank you very much for your attention.
Thank you very much, Mr. Francesca Massanello. Sarah, I can.
Yes, Dr. Eddie, I'm so glad you are here. I apologize. I think you were on before and our signals crossed. But yes, would you like to introduce the next speaker? Thank you so much.
Okay. Thank you for Mr. Francesca Massanello. And it's such an interesting presentation. And he talked about the Sendo, the successes, and I don't know, it's ended because the support of the support, and maybe we can talk about it more in our discussion. And let's go to the next speaker, Salome Flores Sierra Franzoni, Coordinator UNODC Information Center for Researching and Analyzing Transnational Threats Related to Drugs and Crime, UNODC Regional Office for Central Asia, Uzbekistan. The floor is yours, Salome.
Hello, everyone. I think there is a bit of a confusion because we do have a recording from Francesca, and my understanding is that we're going to play that recording first, and then we're going to have a question and answer session. Is that right?
And we indeed have the recording from Francesca. The recording is ready to play. So with your permission, I'm going to play it.
Thank you.
Let's play the recording first. Thank you, Salome.
Thank you. Over to you.
Good morning and good afternoon. My name is Francesca Massanello. I work at the UN Office on Drugs and Crime, and I'm here today to talk to you about the UNODC Drugs Monitoring Platform. I work in our Data Analytics and Statistics section in our research branch based in Vienna. And I'd like to tell you a little bit about how this tool could be particularly relevant to the efforts undertaken under the Global Coalition on Synthetic Drugs. So what is the DMP? The DMP is an online geocoded system with over 630,000 events embedded into the system. So these events primarily consist of individual drug seizures. So what this means is this is about every single event, so every single occurrence or interdiction that takes place in a country where drugs are seized. So we basically use the platform to visualize and disseminate seizure information, and we use this mostly for a tool for monitoring drug trafficking trends, drug trafficking routes, and the modus operandi involved in drug trafficking. We call it a common system, and what we mean by that is a system of give and take. It's not just about the data that UNODC collects, but it's also about the information that is shared with us that is put into the system to harness the value of all the analysis, the data, the evidence, and the events that are happening around the world. It's a closed platform predominantly, and our target audiences consist of the member states, the UN member states. So it usually consists of law enforcement, analysts, customs, and so on and so forth. Basically, what our main objective is with a tool like this is we're trying to put together essential evidence that can assist the international community to, inform policymaking and support operational action. Now, let me tell you a few advantages of the system, and then I'll walk you through some of the elements of it in a little bit more detail so that you can see practically how it can be very useful for you. So as I mentioned before, we have over 630,000 seizure events in the system. Here on the right, you can see the breakdown by different drug groups. And essentially what a tool like this does is it gives us the versatility to monitor and improve our understanding of evolving threats and changes in drug markets. Again, something that is particularly relevant when we talk about synthetic drugs. Now, what I'd like to mention about the data that's in the DMP, so the individual seizures that are recorded in the DMP are not meant to be comprehensive of whole amounts seized in a specific geographical area. The aim is rather to characterize all the main significant seizures to describe patterns and flows of trafficking. So basically what we have in the system is what we like to call a multi-source data set. So we have three main types of data that we use. We have the data that we receive directly from member states through our individual drug seizure data collection, which is part of the individual seizures that countries report to UNODC as part of their obligation under the 3 international drug control conventions. We also make use of a variety of open source information to complement the data that we receive from countries. And we also have data that we receive from basically cooperating partners of the system that is also put into the system. So the point of these 3 different sources is to sort of harness everything all together to make the most of what we're able to offer to the users of the platform. The graph you see here on the left, this just gives you an idea of the distribution of the information that's contained in the system, and it's predominantly made up of the data that we receive from member states, so it's almost 80% of the data. We also like to say that what we have in the data is we try to collect real-time data. So what we realized in UNODC is that even as we improve the data and we have more countries that are reporting to us as part of the formal data collection, there's still a need to use other sources, and this is where the open source information comes in, as well as the partner information. So we try to bring a moving picture to our users, to you, to our audience, and we try to incorporate as much real-time data as possible. Essentially, the system it's a living system where we're feeding data into it every day, so it's not static and fixed in time. What's also particularly interesting, I think, to all of you, the audience, is the universality of the system. So we're able to look at different regions, we're able to look at different drugs, we're able to look also at that global picture. So we can drill down where we need, we can see how those threats are evolving. As I was mentioning, we can also have subnational pictures, regional pictures. It really depends on what it is that the user is looking for. We also call it a flexible data collection and flexible visualizations. And what I mean by this is, again, in the system, what you see on a page, we call a page a dashboard, is basically how you want to interpret it. So you have a number of drop-down filter options, so you can look at different drugs, different years, different countries, different weights of drugs, and so on. So basically what appears on the screen for you is a customized dashboard with an analysis based on what it is that you're looking for exactly. Now, just to talk a little bit more about the products that we have with the DMP and the dashboards, as I mentioned, we have a series of analytical dashboards. So that's each and every page that we have in the system. So we have more than 13 analytical dashboards. We also produce a variety of briefs that are related to drug trafficking, as well as tailored analysis that feeds into quite a number of other reports and outputs that are created by UNODC. So it filters into flagship publications like last year's Global Cocaine Report, as well as the annual World Drug Report. And what's really important to know here is I mentioned that the system is a living system, that it's not static. And what that means is that essentially every day we're feeding new data into the system so that you always have this moving picture available at your disposal. What you can see here on the right are a couple of screenshots from the system, so you have a sense of the kind of visualizations that appear on the screen for users. Now, again, just to make it a little bit more concrete, what does this really mean for the member states and for you, the audience? As you can see here, this is actually a graph that we produced in a recent brief that we published. And essentially what the story it's telling us here, just looking through that lens of the individual drug seizures, is that over time, looking through 2020 and 2022, we can see that the size and the flows of individual heroin and meth seizures suggest that heroin trafficking has continued. This is now looking at the area around Afghanistan and neighboring regions. And although there was a lower rate in Afghanistan and neighboring regions after August 2021 and through 2022, especially along the Balkan route, we do see that methamphetamine trafficking intensified, which really indicates this rapid expansion of the drugs manufacturer. So essentially, the DMP is a tool that can be used to see what is happening, as I said in my first slide, in terms of trends related to different drugs. And you can see this trend of the uptick in the regions around Afghanistan in terms of methamphetamine trafficking. Now here I just want to illustrate another example for you. So again, since we have a geocoded data set that's contained in the system, we're able to produce quite a number of maps. And the story I wanted to share here with you relates to meth seizures. Again, looking around Afghanistan and neighboring countries and neighboring regions. And as you can see, this map here illustrates that, in the years between 2014 and 2018, there was meth present in these countries and these regions, but it was not so prevalent. Now, when we take a look through the data that we have available to us in the last few years, so if we look at 2019 to 2022, you can see there has been a huge boom related to meth. So again, it's a tool like this that lets you see on a regular basis just how much is shifting when it comes to different drugs. And the reason I wanted to highlight this example for you as well is that the tool also has the versatility to adapt to what's happening on the ground. And what I mean by that, and I'll show this to you in our next slide, when we take a context like Ukraine, where you have a shifting situation because of conflict or other reasons, changes in governments and so on, the tool is not dependent exclusively on having a footprint in one country. What's really great about the tool is that you're able to monitor from the outside. And what we see here in Ukraine is that with the outbreak of war and so on, we saw a shift where there were no longer large seizures of cocaine and heroin happening in the country, but there was quite a bit of seizures taking place related to synthetic drugs, which raises many questions of what is happening in terms of the manufacture of these drugs. Are the precursors inside the country? Are they outside of the country? So now I just want to give you a flavor of some of our dashboards. So here I've taken an example of our routing dashboard, which is probably our most popular in the system. And what you can see here in this dashboard is you can see through the map the inflows and outflows of seizures by events. You can also run the analysis based on the volume of seizures, and it tells you really, based on the examination of seizures in a specific country, what is happening. So the graphs also can illustrate for you what is the distribution of seizures by region, by subregion. It can drill down to understand what's happening in terms of what are the countries of departure and origin and destination. There are also other visualizations which depict trends over time. So for example, you can see, is it the same 5 countries where the drugs are coming from as it was 5 years ago? If I'm trying to understand what is the situation, for example, in Pakistan, as we have here on the screen. There are also visualizations that help us to understand, well, what happens when we want to understand what's happening outside the country. So you can see what are the seizures reported for a specific country by other countries. So if you want to know where there have been seizures that have made reference to Pakistan, you can also see that. Now, this is where I wanted to show you that we also have something called a tooltip embedded into the system. So just because of the visualizations that you see on the screen, that's not where the analysis stops. You can actually hover over several of the visualizations. There are prompts on the screen that say tooltip, and then you'll get an additional pop-up window that can tell me, okay, if I want to know where has, for example, Afghanistan been referenced as a departure country, then it tells me as an extra layer of information related to which drugs and so on and so forth. So there's really layers upon layers of information embedded into the system. And what I really want to drive home for all of you here today is that this tool is here for you. It's not just for UNODC's disposal, but it's something that's there for you to use at any time. You know, maybe not every day, but it is there for you to be able to understand and look at that analysis without waiting for a formal report and so on. So here we have another example of a trafficker's dashboard. This is also another popular item in the system. This is looking at the data that we have for Asia, and the kinds of visualizations that you see here on the screen depict statistics related to those arrested in connection with a drug seizure. It can be divided by country, by region, by sub-region. Again, you have drop-down filter options on every single dashboard in the system so that you can customize the search that you're looking for. You can look at the data according to sex, to nationality, the age of traffickers operating in a selected geographical location. It also contains time trends, and it also has the tooltip options, so that additional layer of analysis like what I demonstrated to you on the previous slide. So again, if we look at the tooltip option here on the trafficker's dashboard, if I want to see for a specific nationality, for example, and I hover over a bar in the graph, it gives me another pop-up so I can see for that nationality which drugs have they been arrested for, so we can understand what are the dynamics happening in a country or region. For example, what modes of transportation were they using? What were the physical seizure locations? And so on and so forth. And the last point I really wanted to make here is the power of data. So, as we add more incidents into the system, you can draw more valuable conclusions, right? You can connect the dots and you can make the links. So it's not that 1 + 1 is 2 when it comes to data. We're actually multiplying the power of the data. And I think this makes it much more advantageous for law enforcement and policymakers. And as we continue to grow the system, the addition of information related to production sites, to labs, other information related to arrests or those who come into contact with law enforcement are also particularly important and can make it that much more valuable for you. I'd also like to mention that in many countries, although we're focusing on synthetic drugs here, sometimes we can't look at the drugs in isolation. So even extending to other commodities, to other threats and crimes is also particularly important. And this is where UNODC also has an added advantage related to wildlife trafficking, firearms trafficking, and even now starting to look at issues related to tobacco. So thank you for your time and your attention. As you can see, here is my contact information. If you want to register for access to the system, you can see the link is here. You can also email us to the generic DMP team. And I wish you all a good day. Thank you.